Hello, everyone. Welcome to the daily recap from ACR 2025 in Chicago. This is the day 3 recap. This is day 3 at ACR 2025, hump day. It's the last day of full posters, full presentations, full exhibit floor with all the bad coffee. This year they had pizza and cookies and popcorn and snacks. It was kind of good, so maybe we should do a snack report from the convention floor. But I'm not sure the audience would enjoy that. So instead, we'll cover our favorite abstracts from this third day at ACR. I'm Jack Cush, Dallas, Texas. I'll have everyone introduce themselves. Dr. Reyes.
Hi, I'm Shelia Reyes, and I'm from the Philippines, and I'm joining live here in Chicago for coverage.
Mike Putman.
Hi, I'm Mike Putman from the Medical College of Wisconsin. Also here in Chicago, still at the McCormick place.
And Bella.
Hi, this is Bella Mehta. I'm from New York and happy to go over some of these exciting abstracts.
Yeah, we've got it was an interesting day. It began with I think a strong plenary session. And I think that's where we're going to begin with, is that what you're going to cover, Dr. Reyes, as your first one?
Yes, so I'll start with that since that's also the first session that was covered this morning. So I'm going to talk about abstract, that's abstract 1722. It's entitled Defining Safe Hydroxychloroquine Blood Levels by the group of Dr. Shivani. And the primary objective of their study was to validate the upper threshold for therapeutic hydroxychloroquine blood level monitoring. And the second objective was to identify kidney function thresholds associated with potentially toxic hydroxychloroquine blood levels. So they pulled data from 3 large SLE cohorts from the SLIC, Wisconsin, and 3 French studies. And then baseline levels of hydroxychloroquine, either from serum or blood, were taken, and that was studied too. And so the results show that they had a pretty big population. So 1,842 patients were studied. 4.4% developed toxicity, majority of which was retinopathies from hydroxychloroquine. And what they found is that for levels more than 1,150 nanogram per ml, this was a super therapeutic threshold, and there was really no added therapeutic benefit with potential for more toxicity. And less than that would mean increase in flares. So, and also in terms of kidney function thresholds, they found that for CKD patients stage 3 and above, they had twice higher odds of super therapeutic levels of hydroxychloroquine. And that was even despite weight-based dosing of less than 5 milligram per kilogram. So I think again, it validates some of the previous findings regarding the toxicity thresholds of hydroxychloroquine. And I guess it tells us the importance of trying to find a way to include this in practice in monitoring therapeutic blood levels as well as toxicity levels. And I think I got curious or interested more with that of the CKD because honestly, I don't necessarily adjust hydroxychloroquine that much. So I guess with these findings, we should be watching out more in terms of monitoring hydroxychloroquine levels. Yeah.
So I think this falls under you don't know what you don't know. And, monitoring makes a lot of sense here. Bella, what's your take on this data?
I don't know. I feel like this hydroxychloroquine has gone like a pendulum. First they said don't give too much. Now they're saying don't give too less. I mean the 5 milligram threshold. Now to monitor, like how often to monitor. I understand. I mean, I think we're all going at a very small range. Most patients we're doing fine with. And patients are getting scared and physicians are getting scared. So let's come up with one thing that we can go with.
But I think they were black and white about the numbers,
Yeah.
less than 750, no good, more than 1150, no good, and be in between. Mike, what's your take?
Yeah, this is a funny one where I feel like we went to the same plenary and we had totally opposite takes on it. I have been very frustrated by
Oh,
the tapering
Mike, wait,
hydroxychloroquine that's
Mike,
been
you're
going
going,
on.
Michael, you're going in and out, internet wise. So,
Can you hear me?
yeah, let's start one more time, or maybe move.
Want me to
I
call
see
in? I had good internet the whole time here.
You could, why don't you call in, and use, you can stay on the video, but you call in, and we'll use that when you do your next report. I'll just, I think I was gonna go, maybe where you were gonna go in that, there's a strong recommend.
Is my internet good now?
It's kind of jumpy, and choppy. So,
Kind of jumpy.
yeah,
I
the
apologize. I
internet
thought I had
is.
good internet here.
Yeah, let's, if you could call into that might make all right, so there you are on the call.
Recording in progress.
Yeah, mute your screen, your video screen, and then use there you go. So we got two Mike Putmans on this video feed. That's twice the trouble. All right.
Yeah.
Go right ahead.
How's my audio now?
Yeah. Oh, good. Well,
What do we need to turn up?
I mean, maybe while we're waiting for him, all I'm saying is that how often do you do this, right? Like, patients' compliance has changed for these drugs, so it's fine to do it once and then making sure that this is okay. I don't expect this to be doing this every 3 months. Like, that's expensive. That's
Oh.
not useful.
Right.
Like, once you know that this is an okay dose, then I would just like it's a one-time thing. From a cost perspective also.
I think that
Yeah.
the group that does a lot of it, Michelle Petrie's group, it's not a one-time thing, but it
I
is a
know.
periodic thing, and it's done early on. When you're just doing that dosing. One of the points of the paper was that even when you're doing the prescribing, guidelines of less than 5 milligrams per kilogram, 52% were subtherapeutic, and 17 or 18% were super therapeutic, even though you're in that nice guideline window. So again, you might assume if everyone's doing well and you don't know the levels, then you assume everything is well. But why not optimize things with a tool? And it's not like this is $1,000 test, and it is commercially available. The fact is, it was not available at my medical center before I left there. It is commercially available in a number of places. I don't know the cost, but it's more than a rheumatoid factor and less than a biologic is what I would say at this point. But unless someone knows the actual cost, Mike, why don't you give it a try for a comment?
Yeah, it's funny. This is one of those abstracts where we each went to the same session and we had totally opposite impressions from it. The thing that I thought was the most interesting was actually that levels under 750 were associated with an increased risk of flares, and a dose under 5 milligrams per kilogram was associated with an increased risk of flares. And for me, that's just the most important thing. Hydroxychloroquine retinopathy is rare. It happens in about 10% of people over 10 years, and it's completely preventable from a morbidity perspective. The eye doctors see it, you stop the drug. Very few people actually develop long-term issues with it. And so from my perspective, I am much more scared of lupus flares. And my take home from it was that I want to get people up to 1150, I actually want to go the other way on it. And my preference from seeing the abstract would be to err on the high side.
And I think that was that's kind of what I learned a few years ago. I remember the first report on this at Madrid in EULAR over 5 years ago, maybe 6 years ago. It was pre-COVID when Michelle presented this. All right, let's move on. Bella, why don't you give us your first one?
So I went to this session with the SJI guidelines. These guidelines were updated from 2021 to 2025. A lot of has changed in systemic JIA. Specifically, they're trying to give recommendations on drugs, which ones to use. So patients with MAS and without MAS is the big two brackets that they sort these patients in. And those without MAS, I think they're saying go with any IL-1 or IL-6, no real preference. Try not to do a lot of glucocorticoids. Of course, those with the MAS, you have to add glucocorticoids. But overall, I think the guidelines were trying to minimize steroids. As with all our guidelines. But the other things that they were not recommended were NSAIDs up front, glucocorticoids and up front, or even initial oral DMARDs. Also for patients, after taking care of the initial phase for subsequent therapy, either try, they were preferring biologic DMARDs or JAKs instead of some of the other ones. And again, they were preferring IL-1 or IL-6 agents compared to JAK inhibitors. And sort of for persistent MAS, they did add imapelumab for MAS, and I think it does work well. So it's good that they added it. And then sort of the big takeaway for this guidelines was that all patients, they are recommending screening for lung disease because that's a big problem in the pediatric population, not as much in the adults, but screening probably might be a good thing. It's not really put in practice as of now for adults at least, but it's now there's a strong guideline recommendation. And then the last thing they said is for clinically inactive disease. I like that they want to say, hey, strongly recommend decreasing glucocorticoids, which we all do, but also conditionally recommend sort of tapering or going down on biologic DMARDs. Again, we'll see what the data is, but if it's monophasic or something, it probably does make sense. So, and I think they, from 9 to 15, the guidelines, they have expanded, they're trying to go in depth. But again, all of this is mostly on recommendations, not huge evidence for a lot of the recommendations, but I think it's an important one to talk about.
So the only strong recommendation is this recommendation that they have already had, which is first line treatment is an IL-6 or an IL-1 inhibitor. That was already out there. That's in EULAR, and that is a recommendation. And then they throw the curve at you about don't use non-steroidals. Actually, that's very old ways of thinking about this, and that's fine. It really doesn't work. Although
most people aren't using it. Yeah.
Well, it used to be 60% of the therapy and whatnot. But the idea of not using steroids is, first off, that's conditional. I'm sorry, everybody with stills that ends up in the hospital is going to get steroids, but they're going to, theoretically, they're going to get parenteral. And if you're sticking with, liberal use of parenteral in the early phases, then they can go home not on parenteral, not on oral, if they're on a biologic that is as effective as we think IL-1 and IL-6 is. So I think that makes sense. But the algorithm that I think that Susan Chenoy presented was you get an IL-1 or an IL-6. If you're not doing one, you get the other one you didn't get. And then after that, you're going to get a JAK. And then after that, if you've got, joint stuff, you use joint DMARDs or joint biologics in the mix. But yes, they want you to stay away from steroids. The other thing about these guidelines was that these were an update to both the 2019 and 2022 JIA treatment guidelines. So they also had guidelines on treatment of polyarticular, oligoarticular, arthritis, enthesitis-related disease, new on dactylitis, and new comments on what they call deselection, that you could start to withdraw therapies, which seems reasonable, especially with stills. I don't know how reasonable it is when you have polyarticular JIA, but so I like some of the things that they said. I think I have as usual, concern about a lot of this being expert opinion and conditional recommendation. Any other comments on this?
My one cautionary note on this disease area is that I think we extrapolate a lot from the child side onto the adult side, and I'm really cautious about that. I think they're somewhat different diseases. I think on the adult side, a lot more of it is triggered by some other underlying autoimmune disease, and there's a lot more malignancy. And so I think that often on the adult side we take our cues from the kiddos, but I think that it's qualitatively different, and we have to be
Mike, you
careful.
have to mute yourself. Don't know what that was about.
Yeah, but I guess some things are different, but a lot of things, at least in stills, can be extrapolated. Like there is some level of evidence, but yeah.
Well, the FDA obviously considers them the same, and the nomenclature is it's Still's disease. And the only differences are, in my opinion, the prodromal sore throat is 70% of adults and uncommonly seen up to 15% of kids. Everything else looks the same except this issue, as Bella points out, about lung disease. And they're carrying that banner, and they want to look for lung disease. And I don't know, they didn't say how, so you're going to get a chest CT or an MR on everyone with stills. Again, I treated, I don't know, over 200 patients with stills and seen over 500 consults. I have 3 great cases of bad lung disease in Still's disease. And I'm very tuned into what they're doing, and they get a lot of pleuropulmonary manifestations to begin with. So I think we in the adult world are aware of this. However, I don't know that that recommendation is going to carry through. We need to move on. Mike, what's your big one?
Yeah, my big one was the great debate. I really enjoyed the great debate this year. It was between Wolfgang Schmidt and Tanaz Kermani. So pretty expert people in the field, and they covered a lot of ground that I thought was interesting. Wolfgang always puts on a good show. He established that ultrasound is available. It is fun to do as a rheumatologist. You can get a lot of information that you can't get from a biopsy, such as axillary involvement, and then you can use it to track over time.
So what was tell the audience what the great debate was.
Oh, it was about ultrasound. Oh my God. Off my game. It's about ultrasound or biopsy and giant cell arthritis. Sorry, I jumped right ahead. Yeah. Ultrasound or biopsy and giant cell arthritis. And they covered a lot of great ground. The argument was really around a couple of things. One is how good ultrasound is at finding GCA and being confident about it. The pro ultrasound for giant cell arthritis diagnosis side of it said, hey, ultrasound is 100%. We find it in the axilla. You can't do that in the temporal arteries. It is easy. It is available. Patients love it. It's fun for the rheumatologist. And then the other side said, ultrasound misses a lot. The specificity for a biopsy is nearly 100%. And, if you compare ultrasound to that, you wind up missing a fair amount. And that the biopsy winds up giving you other important information. And then most importantly, there's just not a lot of centers in the United States that can do ultrasound to a sufficient quality for compared to what they're doing in Europe. Wolfgang was sharing his cohorts of over 500 people that he'd done ultrasounds on, and there's very few people in the U.S. who have done anything like that at all. So I really think that it was a fun debate because it sort of synthesized how I feel about this, which is that ultrasound's a great modality. If you can do it, can help you risk stratify people. For folks who are really low risk, a normal ultrasound kind of rules it out. People who are really high risk, and a positive ultrasound maybe is enough to rule it in. Great to see those axillary arteries. But then people in the middle, I'm still doing a whole lot of biopsies. And I think that's going to remain the gold standard in the United States for some time to come. But kind of a fun debate, and I always like that format for learning things.
I think that the idea on this is that not that everyone's going to change their practices right away, because there are technical limitations to not having great ultrasonographers that do a lot of this and are good at this. But I think this coming up and being debated this way lets the rheumatology world know that this is where we're going, that you need to push for this in your environment and where you work. And maybe you're not the ultrasonographer that's going to do it, but having that conversation. At my center, I remember having this conversation going back 10 years when they said we can do it, but we don't know how good we are at it. and now they're reasonably experienced and they can do it. So let me ask Sheila and Bella, is this being done where you're practicing, Sheila?
Yeah, so I think you know, the difficulty or the challenge really lies in the expertise or the being able to do the ultrasound or even the biopsy. I mean, in my center, not all for example, not all radiologists would be trained in doing ultrasound of the arteries. And that being said, even the biopsy. So I guess there really is a challenge in terms of how to use um, these diagnostic tests, and especially, for example, if it's the biopsy, most of the time patients have already been on treatment before they even get to do a biopsy, if there would be one. However, ultrasound is, at least in my country, it's relatively cheaper than doing a biopsy.
Sure. Bella, what about HSS?
In theory, there is somebody who can do an ultrasound, but it really doesn't happen. And the quality, it depends. It's so user dependent, I feel like. And, it's easier, like there's a protocol in place, there's a system in place to get the biopsies. So I still think that most people are sending patients out for biopsies, like even if it's bilateral. Changes takes time.
That's right. That's
And then
right.
there's like all these newer sort of CT and MR protocols which look at the arteries. So those are also done in these iffy cases. So
Yeah, well, and I mean, they should be done with a new diagnosis. You should be looking for the extratemporal other vessels and being involved anyway. So, but making the diagnosis by one method or another is still is going to be the ongoing debate. So my first presentation is going to be a late breaker from today. It was LB 15. And it was from Geneva, 2 centers in Geneva, I think, and 1 center in Australia. They did a small pilot study looking at the role of dietary fiber on microbiome and DMARD responses in RA. 49 patients, yeah, it's small. 1 month trial, that qualifies as pilot, right? An unknown number on methotrexate, it was more than a dozen. And what they found was that when they looked at and it was double-blind, randomized, placebo-controlled, 49 patients, that those who received fiber had improvement in their EULAR good scores and in their DAS scores. Now, let's say right off the bat, these were mild patients. Their mean number of tender joints was 6 or 7. Mean number of swollen joints was 1.8 and 2 in the 2 different cohorts that we looked at. The CRP was roughly 7 milligrams per liter. So, modest activity, but to have like 53% develop a EULAR good on fiber versus 23, 24% on placebo, that's a little eye-opening. And then when they looked at where the benefits were seen, it was in the methotrexate population. Methotrexate treated patients who were taking fiber had a minus 1.0 drop in their DAS score, their DAS 28 score, which would have been low, although I don't know what that number was. It would have been fairly low, but it dropped -1. The placebo population dropped minus 0.38. The numbers here are too small to be significant, but it still is an interesting concept. Now they have a comparator group of like 6 patients on other DMARDs, mainly sulfasalazine or leflunomide, where they showed that being on, again, the fiber didn't change their clinical outcomes. If anything, they got a little worse, and the same thing for the placebo. So I like this as a proof of concept. It goes to, in learning about the microbiome from Jose Scher and others, one of the things I've learned is, the microbiome's cool, but maybe the real secret to the whole microbiome story is what the microbiome does to pharmacokinetics and pharmacodynamics. And we know this to be true in oncology studies, where it's really a big issue. And they're looking for tie-ins, as to how we do it, and why not start with methotrexate. So anyway, the authors of this, who are great in their presentation and fending their choices at poster side, are embarking now on a larger 100-patient trial. Bella, what do you think?
I think this is something, diet trials are hard to do, right? I don't know if it's because of the drug and the fiber itself or fiber itself doing this. I mean, oncology is big on it right now. Like the recent oncology conferences are like, they have like separate sessions on these fiber stuff. And they are showing like improved outcomes, survival even, just by changing the fiber content in the diet. So I don't know if it's completely related to methotrexate or it's just, you eat fiber and you're just overall healthy and your glycemic control is better. I'm not quite sure.
But again, if you look at the graphic, the placebo methotrexate group is here. The fiber methotrexate group is down here with a negative change in that. So it looks like there's an effect. Again, about 12 patients, maybe up to 20 patients in each group there with methotrexate, half on fiber, half on, and the fiber they use is inulin, 12 grams a day, which is often used in other fiber trials and in IBD and GI trials. So again, I don't think this is proof of anything other than, a head scratcher, and let's do this in a big, more solid clinical trial way. Mike, what do you think methodologically about this kind of stuff?
You echoed my thoughts exactly. Things like this rarely translate when you get them bigger. You expect that delta to probably narrow a little bit. The flip side is that, I spend a lot of time recommending healthy diets to my patients, and I'm already trying to encourage them to eat fiber. So this does kind of make me feel good about that. So I'm gonna take the win while disbelieving the data, if that makes sense.
No, I think there's no harm in running with this at this point. So very good. All right, we're going to do one more round. Sheila, do you have a quick one?
Okay, so my quick one is abstract 2634, where they looked into sex differences in medication discontinuation in patients with AxSpA, and data was from the RISE registry. And basically what they saw, so patients were on either TNF, JAK inhibitors, or IL-17 inhibitors. And the results show that women had higher discontinuation risks for TNF inhibitors, but there was really no statistical difference between those taking IL-17 or JAK inhibitors. And I guess the main message here is that it reinforces the evidence that gender differences do exist in AxSpA, and not just in clinical manifestations, but also treatment response. And so that should help us guide our treatment options and individualized treatment.
Yeah, it's obviously a big issue that needs more research, but this certainly helps. Bella, go ahead with yours.
So this is abstract 2, 5, 8, 7, and 8, 8. Basically, these were the dissolved trials and data from that in gout. Mainly chronic gouty arthritis were the inclusion criteria, and they did administer NAS, which is nano-encapsulated sirolimus, plus pegadricase. Again, this is something that they give for every month essentially, and they basically presented data on only patients who were completers, so patients who at least took 6 doses of this. A lot of the patients dropped out, but they never gave us what numbers dropped out. But this was 3 arms: placebo, low dose sirolimus, and then high dose sirolimus, the nano encapsulated one. So again, double blind, placebo, randomized phase 3. And seems like it did do a great job even at low and high doses, but I guess the number of flares were low. Overall, VAS or pain, and tender swollen joints, all of them were low. The side effects pretty much were similar to what other pegylated uricases have out there. I think it's important to know that they didn't present like an intention to treat numbers. They just presented completion analysis. But I think it's a good option to have. We'll see. We need some more data coming up.
I like the technology. I like the advance. I dislike a completer analysis. Why did they? I would have been unmerciful about that. But why did they do that?
I
Because you
think
don't-
they a lot of patients, you need to have uric acid lower than 2 when you're on these pegylated ones. And a lot of patients did not meet that criteria. So they had to stop essentially. And they didn't even present the data of patients who probably took it for 3 months and how did they do. They just gave us the completion of analysis. I mean, it looks great. I mean, but I think in a way, any RCT, if you just look at the completers, you'll feel great about it, right?
Oh, I really, really look great right now on camera on this video. But, there's lighting, there's makeup, there's a team of people behind me that are trying to make this look good. You saw me earlier. I don't look this good in real life. So I don't know. I worry about this kind of presentation. All right,
I think it's an option for pegylated stuff. That's all. We'll see. We need more data.
Right, and they're going to have to put out more data. Mike, what's your last hit?
My last quick hit is a yesterday and today one. This is abstract 2278. They shared some longer term data from Reset RA, which was a study of vagal nerve stimulation for rheumatoid arthritis. So the idea of this is they implant a little zapper in your neck by the vagus nerve. It zaps you, and then via some kind of reflex, it improves your RA dramatically. But in the study itself, the data was relatively mediocre. Only about 35% of people met an ACR 20, which is not a very high bar, so kind of disappointing. And something about giving people a therapy that zaps them in the neck just feels to me like you're harnessing the placebo effect. Now, I actually dropped by the booth today and I said, hey guys, is this all placebo? And they made an interesting observation, which is they surveyed the people who got the treatment, and then they also had a sham group where the treatment wasn't turned on, and they surveyed them to ask, hey, do you guess which group you're in? And they're going to present that data soon, where we get to find out how many people guessed which group they're in. And I think this is really exciting. Unblinding is a big problem in trials, and we never do this kind of thing where we just try to figure out how much it happened. And I'm genuinely, I went from being kind of blasé about this to genuinely excited to see how that particular part of it plays out, even though I'm overall pretty skeptical of vagal nerve stimulation.
Yeah, it's obviously a new entity, just recently FDA approved.
Yep.
FDA approved based on a 40-ish% ACR 20 at their first time point, which was week 12.
Yeah.
And a very low placebo rate that was below 20%. So that was, that's what made it all significant. This issue of unblinding was brought up in the presentation, and it was discussed, and you I think portrayed it very well. The other thing is that most of these people are going to get their 1 minute of vagal nerve stimulation in the middle of the night while they're sleeping.
At 4 a.m. Yeah.
And the company's point of view on this is that, well, how do we know? How do they know? It's a brief thing and whatever, but I don't know that that's good evidence of maintaining a blind, because if you've ever seen nighttime photos of people sleeping and the things that wake them up, including dogs and spouses who have a flail arm and whatever, they don't remember any of it, but it happened, and they were subjected to interferences and whatnot. So anyway, it'll be interesting to see. I think there's enthusiasm about this approach because it's a non-medicinal approach, but it certainly has some challenges to it, including it has to be implanted by a neurosurgeon, and there are going to be certain centers that will do that. So,
Well, you know
But-
what can stimulate vagus nerve naturally? Exercise, music,
Yeah.
meditation. I mean, those things are things that we want our patients to do more than a minute a
Yeah.
day, and it might have effects too. So, it's those are the cheap ones to do to ask.
You know, I
patients.
actually really like that because I've already had a couple patients asking me about that and I didn't quite know what to say. And so I think that's going to be my take home point, that there are many other ways to do this that have other ancillary benefits and no surgery.
all right. I like the idea of the controversy creating a conversation, which will make people and patients better. My last one is another late breaker, LB06, from Frank Behrens. This was a head-to-head trial of secukinumab versus ustekinumab in psoriatic arthritis who previously were treated with TNF inhibitors. And the 119 patients with on average 14 tender joints and 7 swollen joints randomized to get standard doses of secukinumab or ustekinumab. And the endpoint here was a week 28 response. Secukinumab was better than ustekinumab at an ACR 50 of 48% versus 24%. Similarly, the PASI 90 scores were better, but a little bit closer here, 48% versus 40%. Secukinumab over ustekinumab. We don't have many head-to-head trials in rheumatology, certainly in psoriatic arthritis. I think and there are no different safety signals here. So reasonable size trial. I like the head-to-head study. I think this will probably get published and whatnot, but it looks good. And does this reflect what people will do? Remains to be seen. Okay. All right. So let's close out here. We want to thank our audience for listening to this day 3 recap. We're going to conclude the meeting tomorrow with a day 4 recap. Mike Putman's going to host that because I'm going to be in another meeting, but same time, 5 p.m. Central. Tune in either here on Zoom and RheumNow or the RheumNow website or X or LinkedIn or Facebook. We're going to be live streaming. Everyone, thank you very much for your contributions. We loved it.